State's Food as Medicine Task Force. I just want to sort of flag that we have one more meeting that we're planning that we're hoping to schedule, and it's our really sincere hope that between now and the start of when Rep. Dathan and Rep. Kennedy and I can be introducing bills, that we have something that is in a position that all of the agencies that have played a role in contributing and all the stakeholders from the community feel comfortable with the type and form of the bill that we're going to be introducing. So we're going to work between this meeting and the next on synthesizing what we've heard from every agency so far and putting forward a proposal. We'll have that proposal for you all to read ahead of time, ahead of the next meeting. And then we're hoping to get your feedback in that next meeting and then be in a good place to have a bill introduced. It'd be really helpful for agencies who are not contributing to the conversation today, but who had shared earlier, if things have changed, or if you have shopped the idea around more in your agency since we met, and you know of additional barriers that we should be planning for, additional staffing, whatever those things are that are necessary to make these things happen, just please make sure that we know and understand what those challenges and barriers are so that we can address it comprehensively in our legislative proposal. So with that, just a reminder, I'm Jamie Foster. I'm the state representative serving Ellington, East Windsor, and as of January, we'll also be serving a small part of Vernon. And I am very excited to be working with you all on the state's Food as Medicine working group. There's a lot of folks and momentum in this room, a lot of leadership that can help make these kinds of things happen, and I'm very excited. We are going to spend a little bit of time doing introductions today again. Please just be swift, say your name, your agency, and how your agency's role, believes that they're going to be a part of this process, because people have changed since the start of this work. So I'm going to call people instead of popcorning it, because I think that makes it move faster. So I'm going to start with Kaylee, because you're in my top left.
Great. Hi, everybody. My name is Dr. Kaylee Royston. I am the legislative liaison here at the Connecticut Department of Agriculture. I'm joined by one of my colleagues who may get called on later, but I'm just going to go ahead and throw out Erin Wyndham, who is here with me. The Department of Agriculture primarily deals with, in relation to this, our Senior Farmers Market Nutrition Program and our Farmers Market Nutrition Program. We are sort of boots on the ground as far as farmers markets and connecting people to nutrition at that avenue. I will quickly toss it over to Erin to see what else she has to add and let her do a quick intro, and then my agency is good.
Thanks, Kaylee. As Kaylee said, Erin Wyndham, Connecticut Department of Ag. I coordinate the Farmers Market Nutrition Program as well as staff the Connecticut Food Policy Council.
Thanks, Erin. Megan Baker.
Good morning, everyone. Megan Baker. I am the lead Asian American Pacific Islander policy staffer for the Commission on Women, Children, Seniors, Equity, and Opportunity. We're kind of a policy shop under the General Assembly as a nonpartisan commission. And we also are preciously placed to receive input from community from all of our staffers. So in that way, and working with those components in tandem, kind of feeding the work from those perspectives.
Thanks for joining us today. Brent Miller.
Good morning, everyone. My name is Brent Miller. I work for the Connecticut Office of Health Strategy in the Health Innovation Department, and we have been focused on social determinants of health, health equity, and community health at large.
Great. Thanks so much for joining. Brent Ling.
Good morning, everybody. I'm Brent Ling. I'm Director of External Affairs at Wholesome Wave, and we are working on advancing produce prescriptions in standard practice of healthcare.
Great. Rep. Dathan, I'm sorry, I should have let you go first.
No problem whatsoever. Good morning, everyone. I'm Lucy Dathan. I represent Norwalk, New Canaan. I sit on Human Services, Appropriations, and Insurance. And great to be part of this discussion to see what we can do going forward in the next session on this issue.
Thanks so much for joining us. Sophia Perez, thank you.
Good morning, everybody. I'm Sofia Segura Perez. I'm the Chief Program Officer at the Hispanic Health Council. We are a statewide organization, and under me, I have 20. There are 20 community-based programs. One of them is a SNAP a statewide program where we deliver nutrition education and also promote besides promoting good eating habits, also exercise among low-income community. We especially target the biggest 7 cities with the highest rate of SNAP participants. And I'm also a Hartford commissioner, Hartford Food Policy Commissioner, and I belong to other working groups in the area of improving access to healthy foods in the state. So I'm very happy to be here.
Thanks so much for joining us, Sophia. Dan Giacomi.
Good morning, everyone. Dan Giacomi. I'm the SNAP director for the Connecticut Department of Social Services. Obviously, the SNAP program is within our purview, as well as the Medicaid program and Medicaid eligibility. I believe I'm joined today by Dave Seifel, who I will let introduce himself as well.
Thanks, Dan. Yeah, Dave Seifel, Legislative Liaison with Department of Social Services. Like Dan said, yeah, we have SNAP and Husky, so there's a lot in our purview that's related to this. So we'll be excited to see some language. Thanks.
Great. Thanks so much, David. Judith, Dad.
Good morning. I'm Judy Dowd, and I work for the Office of Policy and Management in the Budget Division, overseeing Health and Human Services section. And the other OPM people that normally attend are unable to. Oh, no, I see Heather here, so she can introduce herself.
Great.
Thanks, Judy. She's correct that normally Zani is here representing the Health and Human Services Policy and Planning Division, but I'm here in his stead and happy to be here. Thank you so much, Representative Foster.
Thank you. Erin already went, so Jen Vinci, DPH.
Hi, good morning, everybody. My name's Jen Vinci. I'm with the Department of Public Health. I don't know that Miriam Miller, our legislative liaison, is on, but if she is, I'll go ahead and let her introduce herself after me. But I did want to just say that, we are happy to continue to serve in the capacity as a subject matter expert in nutrition. And we're also happy to work with other agencies that might be directly involved in proposed policies through education, similar in how we work with DSS on SNAP Ed.
Thanks for joining. Sally Mancini.
Hello, everyone. Good morning. Sally Mancini. I'm the Director of Advocacy Resources for the UConn Red Center for Food Policy and Health. And our mission is to find solutions to food insecurity, for diet quality, and weight bias through research and policy. Happy to be here.
Thanks so much, Sally. Michael Warner. He looks like he might be frozen on my end. We'll come back to him. Megan Smith.
Hi, good morning. I'm Megan Smith, the Senior Director of Community Health Transformation at the Connecticut Hospital Association.
Thanks for joining. Michael, you were frozen there for a moment. Would you like to introduce yourself?
Hello, I apologize. My internet connection is not so good this morning. I'm from the Commission on Women, Children, Seniors, Equity, and Opportunity.
Thanks for joining. Lanika Blackman-Carr, would you like to introduce yourself?
Yes, and good morning, everybody. Lanika Blackman-Carr, Assistant Professor of Community and Public Health Nutrition at the University of Connecticut. Glad to be with you this morning.
Great. Melissa Carr.
Hey everyone, Melissa Carr from Unite Us. We help address SDOH through coordinated social care networks, and I drive our Connecticut strategy. Nice to meet you all.
Thank you. Cass. Cass is clerking, so she might not be able to hop on.
Oh,
right
I'm
now.
sorry.
That's it. I don't know if you expected me to call on you.
No, I did, to be honest,
Sorry.
but I hope everyone's doing well this morning. Thank you so much for joining us, especially after the Thanksgiving holiday. I hope everyone had a relaxing Thanksgiving.
Great. Thanks, Cass. Katina.
Hello, I'm Katina Gianteras. I'm with Wholesome Wave, and we work with advancing produce prescription programs.
Thank you so much. Brian Cornier.
Good morning. I'm Brian Knoyer, Director of Government Relations at the Connecticut Hospital Association.
Great. Rafael.
Yes, I'm Rafael Perez Escamilla. I'm a professor in the Department of Social and Behavioral Sciences at the Yale School of Public Health. I have been a household food insecurity researcher for 3 decades now, doing work both in the US as well as globally. I'm also the principal investigator of the Yale Griffin Prevention Research Center, and I work very closely with Kathleen Tufani and Beth on food prescription programs in partnership now, also, of course, with Wholesome Wave and the Hispanic Health Council in Hartford. Thank you. Happy to be here.
Thank you, Rafael. Adam Shayevich?
Hi, everyone. Yep. Hi, everyone. Adam Shayevich. I'm the Chief Program Officer at About Fresh. We offer the Fresh Connect prepaid debit card solution for administering produce prescriptions. Thank you for having me today.
Thanks for joining. I see a Jay Houghton. While they're trying to join, Claire Botnick.
Good morning, everyone. Claire Botnick, Office of the Governor. Glad to be here.
Thank you. Hillary Felton-Reed.
Hi, good morning, everyone. I'm Hillary Felton-Reed, and I am a contract lobbyist with Robinson and Cole, and here today representing Unite Us. Thanks for having us.
Thanks, Hillary. Max Perkins.
Senior Government Affairs Manager for the Northeast for Unite Us.
And I believe the last phone number is Kathleen. Checking it in my cell phone. Nope. I have a 631-375 number.
Hi, good morning, everyone. This is Erin Winorski. I am the Business Development Manager. I work with Adam at About Fresh. Nice to be here.
Thanks so much. Thanks for joining. All right. Without any further ado, I'd like to defer to Rep. Dathan to see if she has anything to say before we sort of kick us off today for a discussion on the framework from our two agencies who are contributing today.
No, nothing specific. I'm looking forward to hearing from the agencies, but I do hope that we get input from the other agencies who haven't been able to weigh in so that we really can put forward some meaningful legislation in the next session. So thanks for organizing.
Thanks so much. Okay, so we're going to start today with the Office of Health Strategy. They're going to be sharing their proposals, ideas, and thoughts related to legislation on food as medicine, and I would love to hear from them and see what they have to propose today.
Great. Thank you so much, Representative Foster. Can everyone see my screen? Or maybe more appropriately, can anyone not see my screen?
It looks good to me.
Okay, perfect. So if you missed my introduction earlier, my name is Brent Miller. I work for the Connecticut Office of Health Strategy and their Health Innovation Department. And today I'm going to be talking to you all about how we are kind of handling this food is medicine and social determinants of health at large. So our agenda, I know I don't have a lot of time, so we'll look at addressing the root causes, interventions and community involvement, some considerations for you all, and then I'll open it up for questions and discussion. So at OHS, Office of Health Strategy, when we're thinking about issues like food insecurity or food as medicine strategy, we really like to start with addressing the potential root causes. And I think potential is an important word to add in here because we don't know if an item is really a root cause that's driving poor health until we put forward interventions and then measure against that intervention to understand, is it making change? And really, potential also kind of opens up this opportunity for us to look at it and say, you know, when we're looking at these different kind of things, we always don't get the outcomes we're looking for. And when we don't get those, that's okay because we learned something, right? We're probably looking more at correlation instead of causation. And sometimes we do get the outcomes we want, which is great, and we can move that forward and standardize. So when we're thinking about root causes, there's a handful of ways we can get at it. I like to talk about the A3 process. A3 is really just the metric size of paper. In our system over here in the United States, it's probably about 11 by 17 inches. This process has been described in the Harvard Business Review, specifically looking at Toyota and the Toyota production system to see why they've had success, especially in the areas of problem solving and quality. And there's a few different tools one can use when we're thinking about, getting at the root cause. What is driving poor health? So the first one, for an example, is the 5 whys. And this is where you really have to embrace your inner 5-year-old, if you will. And you ask the questions, why are people experiencing food insecurity? Well, maybe it's because they don't have a grocery store. Well, why don't they have a grocery store? And that just continues to cascade until you can't get any further. And oftentimes we find that this branches out, and that's okay, right? There's often multiple items that are causing an issue at the end of the day. Another tool we can use is something like an Ishikawa or bonefish diagram, which allows us to look at the industry and all the different categories that may be influencing these outcomes that we're having. And then the last is data. And there's a famous quote that I think is appropriate from Dr. Edwards Deming, in which he said something to the effect of, "In God we trust, everyone else bring data." And when we're looking at these problems, we really need to understand where the data is showing us the issues lie, even if it's directional, right? And how do we measure against those items moving forward to see if we're making the change that we want? When we go through this process, we typically have been finding what is driving poor health. Are social determinants of health, or you may be familiar as some social drivers of health or social influencers of health. And I think this group is probably very familiar with this term, but I thought it may be helpful for us just to do a refresh. This definition comes from the World Health Organization, right? Social determinants of health are the non-medical factors that influence health outcomes, the conditions in which people are born, grown, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life, right? That's employment or the lack thereof, that's education, that's food insecurity, that's lack of access to healthcare, that's racism, right? All of these things are driving health outcomes. And so when we're thinking about root causes and getting at these items, we really like to embrace community voice and community leadership. Back in the SIM days, the State Innovation Model Grant days, when we were doing a lot of work with communities and engaging with them, there was a quote from one of the residents, and it either came from Hartford or Bridgeport, depending on who you spoke with. But this resident said something to the effect of, "Nothing for us without us." And I think that's really important as we think about these issues, because they're multifaceted and they're very deep-seated. And when we think about putting forward interventions, how do we work with the community to not only understand what are the causes that are driving poor health, but what are the appropriate interventions to put forward, which leads me on to my next slide, interventions and community involvement. So at OHS, we've really been thinking about interventions as 4-pronged. The first we can think about our policies, right? And I think I have some back, great, thank you everyone. So first one we can think about is policies. So what are the policies that are at play today, right? Are they doing enough? Are they not doing enough? Where's the gap that we need to fill? The other is systems. What are the systems that are at play that are creating the health outcomes that we have today? And do we need to change those? The next is programs, right? And I think throughout the course of this work group, we have heard some really wonderful programmatic interventions that I personally am quite excited about. But what are the programmatic interventions that we need to put in play to make some kind of change to meet that delta? And then lastly is cultural norms. And I think this is really important. I don't know if it was 2 or 3 years ago, pre-pandemic, if you will, OHS had a few visitors from a Southeast Asian country who emigrated here to the United States specifically Connecticut, and they talked to us about their experiences with the government, with the healthcare system. And what really resonated with me is that the country that they came from, the government was committing genocide against them. So when they came over here to the United States and the government was doing reach out, they were not overly enthusiastic about engaging because the last government tried to kill them. So how do we work with all the different cultures that are in our communities to make sure that when we think about policy systems and programs, that we're meeting them where they are, right? And in that specific example, community health workers were a great avenue of getting them involved in the healthcare system. The next piece I would highlight is that no one agency, organization, or group can tackle this issue on their own, right? And I don't think that's a surprise to anyone at the table today. This is a huge issue, and really how we've been thinking about it is government sets a clear, measurable goal, right? They take the poll, they stake it in the ground, and they say, this is what we want to do. Is it a reduction in food insecurity? Is it looking at A1C levels? Is it looking at diabetic levels? Is it looking at access to healthy food and nutrition? What are we ultimately trying to achieve? And then once we know what that goal is, that measurable goal and X amount of years that we want, really working with the communities to understand the root causes, which I alluded to earlier. And then in turn, working with communities and multi-sector organizations, which include the faith-based organizations, the community-based organizations, the hospitals, the FQHCs, the schools, the list, it goes on, right? As well as those government agencies who have an interest in this to determine what's the alignment. Are we all in on the same goal? And if so, how can we all work together from the top to the bottom and the bottom to the top, right? And what are those interventions, those policies, systems, programs, and cultural norms that we need to put forward to make change and meet our goal? And I think a really nice example of this, how this has worked, is something OHS has done called Health Enhancement Communities. You may be familiar with them. There's a group in the greater Middletown area that has been looking at maternal health, specifically mortality and morbidity, and really tying that in with nutrition, which is why I want to talk with you all today. And this Health Enhancement Community, or HEC, is led by a faith-based organization, and they have partnered with the local independent hospital to deal with this issue because the data shows very clearly that women of color, Black, Brown, Native American, have significant disparities compared to their white counterparts. So this faith-based organization, the Ministerial Health Fellowship led by Reverend Robin Anderson, decided to apply for a grant with OHS, the Office of Minority Health. And with that money, they were able to start a program with Middlesex Health called Pregnant with Possibilities. And specifically, they look to target women of color from when they become pregnant to 1 year postpartum through an intervention of community health workers / doulas, and really work with those women to make sure that they're getting their social needs, that they're getting their nutritional needs met, and education, and then also access to healthcare, right? And really partnering with that Middlesex OBGYN group to make sure that mom is as healthy as she can be. Because I don't think I'm making too bold a statement of saying that, the health of mom may very well impact the health of baby, right? So how can we make sure mom is as healthy as possible and has the best start? And something I've learned from the data as well is even after postpartum up to 1 year, a lot can go wrong. And that's why we continue to engage. And this is a wonderful program. And I'll get into this in the considerations in the next. Now, where we kind of fall short is that we really don't pay for these things in the United States, right? We don't pay to address social determinants of health. When I think about who is Commercial payers wise, I think of Centene, right? They are managed Medicaid for several states, so they have a financial incentive. And then if we think about the different states who are doing this, in terms of what I understand right now, it's California and North Carolina. And then I've heard some rumors that New York is thinking about it or maybe putting it forward to kind of address these issues. And so this is a great example of where a program that is doing a lot of good, specifically thinking about food insecurity and improving the health of mom, the health of baby, right? Babies are our future, is going to end in a couple months. But this isn't all happening in a vacuum. I think another great example is Hartford Hospital. They made the news in May with their Food for Health Center, which is a part of their Food is Medicine strategy, in which they are giving clinical referrals to get healthy foods and produce to their patients. And then those patients are also getting education from nutritionists from that on-site location that they go to. And then those patients also have a clinician follow up, and they're able to get fresh and frozen foods. And from my understanding, they've had about 800 visits to date since May, which is really wonderful. So for this last piece is considerations for this work group and some things that we've learned at OHS along the way. Well, we have been working through these different social determinants of health, thinking through problems like food insecurity. We found that through the grant system, we are losing trust. So there's a lot of different brands who are going to the community and saying, hey, I want to help you with X, Y, or Z. And they say, great, let's do it. And then we get a grant, we move forward, and we do it for 1, 2, or 3 years. Sometimes these give the outcomes we're looking for, and sometimes they don't. But at the end of the day, the grant ends, the funding ends. There's no sustainability, right? Again, alluding to the fact that we don't pay for these things. And so one of the things that I would ask for you all to consider is whatever we do with Food is Medicine, ensure sustainability is kind of baked in before we do further expansion, especially as we think about trust with our communities. And that's really, said with appreciation that these issues may take years to show improvement, right? As we thought about all those different items that are driving people not to have access to food, it may take a very long time for us to address those. The other part I would ask you to consider is funding focused more on prevention and less on sickness. In the United States, again, I don't think I'm making a bold statement here. We don't have a healthcare system. We have a sick care system, right? And I appreciate also that Rome is burning and we need to put out the fire. But as we're putting out the fire, let's also focus on how do we put dollars, put resources to help the prevention so people don't get as sick. And a lot of that, I think, is going to be focused on funding. When I used to work for hospitals, I would report out on case mix index, right, which is specifically looking at the acuity of patients. And as acuity goes up, typically your reimbursement goes up. We reward the appendectomy over treating depression if we pay for depression at all, right? So as we think about funding these different things, how can we move the dollars upstream to reward institutions and organizations for keeping people healthy instead of them getting sick? And this really speaks to something called the wrong pocket problem. And I think anyone here who works in the public health space could probably speak to this better than I can. But essentially, a lot of the interventions that go forward that are upstream, that are looking to prevent poor health, really don't see the financial return at the end of the day, right? That financial return typically is going into the pockets of providers and payers. But the people who did the work don't actually see those savings. So as we think about what are we going to do, how can we take the savings that are generated from creating prevention and move that back into the people who are doing the work, which, as we talked about earlier, thinking about, how do we work with communities and those different partners? How do we move those dollars into communities? right? The faith-based organizations, the community-based organizations, the grassroots organizations who have trust that can do this work to solve these issues. And the last piece for consideration is that we're ultimately better together. This is a big issue at play. It's not just the communities, they can't fix this on their own, and the government can't fix this on their own. The hospitals can't do this all through their community benefits. The faith-based organizations and their pantries can't fix it on their own, and the community-based organizations and the schools can't fix this on their own. But really thinking back to that last slide, where do we create, what is our goal? How can we all work together to meet that goal? And almost as if we're a crew team, right? Getting towards that end point. How can we row in the same direction to try and redress these issues that we have before us? So with that, I'll pause if there's any questions or discussion.
Before we start taking questions from everyone else, I'm sort of curious, on the last slide, Brent, here you have opportunities for us all to work together. I'm not sure how many of you all read the testimony that was on this bill when it was introduced to Human Services, but one of the things that was proposed, in addition to covering fruit and veg prescription programs, and we have some opportunities for mechanisms financially for covering that have been discussed in previous meetings when Shilpi came to testify, but one of the things that was proposed in that original bill was making sure that we were sort of maximizing every health and nutrition related program that the state has. And we do have a little bit of, I don't want to use the word siloing, but we do have places where the opportunity for collaboration and intersection isn't as obvious and transparent as it might be. So I think DPH shared the example of SNAP-Ed, which is in the DPH department, but also WIC is in DPH. And so there might be people who are getting education through or eligible for education through SNAP-Ed and through WIC. And are those being layered to offer the families the best benefit or the most time savings when one or the other might cover another program? And what about the FNEP program, which is also federally funded but offered through the state? Are we coordinating that education-wise? And that's just the three sort of biggest education programs that the state has. There are 2 or 3 times as many feeding programs that offer nutrition assistance that have state and federal input. And so have we really leveraged those all as we're talking about adding in more? And so I'm curious if the agencies have thoughts on that. So that have been sort of spurred by Brent's presentation and discussion here. I'm curious, perhaps DPH, this is a place that you all can weigh in on, but is this something that we have thought about and considered, like what's the best way that we're leveraging nutrition education? If we go to this place where we are paying for fruit and veg prescription programs, what's the best way to maximize the nutrition education that is already paid for through our state budget? What's the best way to make sure that everyone who's getting a fruit and veg prescription program is also getting SNAP-Ed or FNEP or WIC or a program where their family is being offered an opportunity for education? Is there a way to coordinate, even though we would be talking about crossing agencies?
So I can go ahead and just jump in real quick from DPH. You mentioned, Jamie, or Representative Foster, excuse me, that the SNAP-Ed programming is something that we would want to consider. And although we do have 1 of 5 implementing programs held within our agency here, we would definitely defer to DSS on that because they are the state agency that actually holds the grant and administers it from the USDA FNS. So if there was some sort of coordinated effort, that any ideas that DSS has on that topic, we would certainly jump on board and be supportive of that. And then also to address your question, or rather your comment about layering of interventions across programs and agencies, I do know that our WIC office does work very closely with the Department of Agriculture. There is the farmers market incentive that I know every year both agencies coordinate very closely to ensure that the WIC population receives additional fruit and vegetable dollars to use within their communities at local farmers markets.
And often there's other education opportunities that are at farmers markets. I think maybe farmers markets are a really good example of where we do sort of have this health education hub happening, because someone could be getting SNAP Ed, because SNAP Ed is often at, I don't know about everyone else's farmers markets, but they're always at my farmers market. And we're doubling SNAP, WIC, and senior farmers market vouchers at my, and so we're offering these programs. We have FMNP, we're given, and there's education on site. And so I'm curious sort of if there are other opportunities that we're missing that give us the chance to do that sort of same education. It seems like in the fruit and veg prescription data, for example, the outcomes are significantly better when education is also happening. And so where can we have that occurring, that it's already existing in our system?
Yeah, I would like, I'm Sofia Segura Perez from the Hispanic Health Council, and our SNAP Ed program has conducted several initiatives where we have partnered with Harpo Food System in their mobile market, which was initially the mobile market was resulting of community-based research that conducted by the Hispanic Health Council, where the community in Hartford, Hispanic Health Council in Yukon, led by Dr. Perez Escamilla, where the community say that the best solution for their lack of access to fresh fruit and vegetable was to have a mobile market that offer a variety of fruits and vegetables culturally appropriate around the neighborhoods in Hartford. And we conducted a study years ago where when the mobile market was a reality. The first 2 years we did a customer satisfaction and also evaluation, a randomized study of the effectivity in increasing fruit and vegetable intake among the targeted community. And we found we were also offering incentives, $20 incentive to the intervention group. And we did found a high satisfaction level among both among those receiving incentives and not receiving incentives with the mobile market in terms of the service that the mobile market was offering. But the incentives were able to increase intake of fruits and vegetables, but that there was a tendency to increase also vegetable, but didn't really was significant. So we thought that was in part was because it was just a small incentive, $20 incentive with the community, but we did found a lot of good high satisfaction rate and feedback about the people were happy to have that mobile market around the community in the neighborhoods in Hartford. What happened that recently last year due to the pandemic, it was negatively affected the running of the mobile market. So we were always working, the SNAP Ed program was always offering activities with the mobile market in all the stuff that they have, but due to the pandemic, we have to stop it, and then lack of funding really at the end of, we have to end it last year, the partnership with Harpo Food System and us. So that was something, an initiative that due to lack of funding, was not able to continue. But it is a very good initiative that we have here. And it's a good effort, an example of a good effort that was conducted with the SNAP Ed program in initiative in the mobile market. We also Hispanic Health Council is also a member of community supported agriculture of Holcomb Farm. And through many years, we have offered nutrition education every summer during the season, nutrition education, cooking demonstration with them, and offer free organic vegetable to the clients of our maternal and child health programs. So that has been also a very successful initiative that we have done. And in the past, we have also worked with Farmers Market in New Haven, offering cooking demonstration. But the thing is that there is kind of lack of coordination sometimes, or lack of funding for offering the cooking demonstration, because we are statewide, but there is a lot of potential of, in my opinion, we've been trying to do different things, but at the end, lack of funding to support those type of partnerships seems to be a barrier. And because SNAVED really is a good funder, but cannot fund everything, you know. So to continue with this partnership, we are currently working with Wholesome Wave in assessing the effectivity of offering incentives to pregnant women. To pregnant women, those incentives will be higher pay, about $100. And we are going to just start it very soon in partnership with Wholesome Wave. I don't know if they want to talk more, or Kathleen or Rafael want to talk in Yale University. But all those type of initiatives, I think, are important and can be facilitated for better coordination, in my opinion.
So I'm hearing sort of this conversation about coordination, sort of making sure that we're maximizing things across them. That was sort of key in Brent's conversation. I want to make sure that if we have questions for Brent, we take those before we move on to our next presentation. But I see Brent's hand up, followed by Aaron.
Yeah, Jamie, thanks. I was going to just respond to your point on coordination. One is to echo and provide support that when coordinated, we see better results for both nutrition education and the produce prescription or the SNAP incentive or whatever is connected. So just echo that. But thinking of this as like a typical prescription drug, you get the prescription from your provider and then you go to the pharmacy. At the point of pharmacy, the pharmacist provides some education about how the drug works. And if it's more complicated, they spend a lot of time talking about it. And hopefully it's the second time you've heard that because your doctor also gave it to you. I would encourage us to think about this similarly. The produce prescription offers lots of different points of contact. So similar to filling a prescription, you have to go maybe once a month and have a quick conversation with the pharmacist. Maybe it provides an opportunity to ask questions about how to maximize the impact. You can talk to your doctor, think of them on parallel paths. And I don't know how to write, I'm on the ground, we do practical implementation work. I don't know how to write SNAP-Ed policy so that this is possible, but the produce prescription model offers points of contact. So one is the enrollment form. You know, if your doctor refers you, maybe you go to a website that says, this is my name, this is my address, here's my doctor who referred me. At that point, there can be lots of resources on nutrition education that people can enroll in there. So that's one point. But also once a month or so, depending on the model, when there's a reload, the patient gets a text message. Hey, your card was reloaded. You used your produce prescription, or the box of food is actually delivered to your doorstep. Here's your prescription for the month. That can also include connections, but only works if the provider, the vendor for that produce prescription, has timely and accurate information about what types of nutrition ed resources are available to the patient. And again, I leave it up to the policymakers to write the policy so that that information is current and active. But any vendor would point people towards those resources if they knew that those resources would be available once the patient went to click through or what have you. I hope that makes sense.
It makes a lot of sense to me. Aaron, I noticed your hand went down. Do you want to still share? Okay.
I was just going to echo what Jen was saying. Thanks, Jamie. That we do partner with other state agencies, but we also really depend on our community partners for that education piece. So for the Farmers Market Nutrition Program, we run the distribution not only through our WIC partners, but with senior agencies on aging and a lot of our senior centers, senior housing units that are doing that nutrition ed. They're also doing the eligibility verification on several programs so that when they're applying for one program, such as the Farmers Market Nutrition Program, they can also determine whether they're eligible for SNAP or those other programs that are available, which we find really helpful.
I appreciate that being shared. I see Raphael's hand is up. We can't hear you, Raphael.
Okay, can you hear me now?
Yep, that's better. Thanks.
Okay, so thank you. So the comment I wanted to make is that after waiting for 5 years, the new week food packages rule is out based on the 2016 NASEM, National Academy of Science, Engineering, and Medicine recommendations, and it is open for public comment. And it is very important, I think, through this effort, those of you that can participate in advocacy efforts to go into the website and support as much as you can. And the good news is that it increases substantially the cash value vouchers for produce, for fruits and vegetables, above and beyond what was already increased through the pandemic. So as Sophia mentioned, we're now reaching an unimaginable milestone whereby people may be receiving $150, $175 per month for increased fresh fruits and vegetables. We started with $10 a few years ago. So when we have the week combined with what Wholesome Wave is doing and others, this is a very, very unique opportunity for coordination and making sure the produce is accessible in the communities. And that's where the comment that Sophia made about the mobile units and so on, and coordination among all food systems actors becomes paramount, because who knows when we will ever get an opportunity like this in our lifetime. Over to you.
Thanks so much, Rafael, for sharing that and for that opportunity to testify. I see that Heather has shared in the chat that DSS has a calendar for all SNAP-Ed programs to contribute to that has the opportunities for education. That certainly could be something that if the additional nutrition assistants through Food as Medicine had an opportunity to text or email folks, they could be sharing that calendar of opportunities. And I'd like to flag that there's really good data on 2 Connecticut state programs related to SNAP-Ed. The Hispanic Health Council has a digital like YouTube series for parents and kids. And Sophia, I'm sure you can clarify me where I'm wrong, but really excellent data on nutrition education and promoting fruit and veg liking for young people in Spanish and English. And USJ has a telephonic SNAP education program that also has really fantastic data on its efficacy. And that program was validated and evaluated before the trends of all of our programming going virtual. And the data on it was really good. It had great efficacy. And so there are opportunities for people to engage in in-person, telephonic. I think the Hispanic Health Council has YouTube videos that they have shared, right?
We did someone during the COVID-19, and we have 2 very good videos promoting even before COVID, promoting the farmers market in the double SNAP. In English and Spanish, and I can send it to all of you. You can see it. But those initiatives were very good in bringing more clients to the farmers market when they were promoted at DSS. That was before the pandemic, 2017, 2018. And they continue to be a good idea of producing videos promoting the farmers market, and double SNAP is very good. It resulted in a very good initiative.
I'd appreciate if you could share those resources. So I'm just going to flag for the last third of this meeting, Rep. Dathan is going to chair because I am unfortunately double booked today for another project that I'm working on. But what we're going to be doing is we're going to be transitioning to the next agency presentation. But Rep. Dathan and I have been in close communication about this. There's also 2 groups, Unite Us and About Fresh, who are in the meetings today for the first time. And so if they have an opportunity to share and there's time, I would love for that to happen. I will be tuning back in later to catch up on what I missed. And thanks so much for taking the baton, Lucy. Have a great day, everybody. Thank you so much for everyone who shared.
Thank you, Rep. Foster. I appreciate all your hard work on this, and your energy is really getting this front and to everybody's thoughts in the legislature. So thank you. Is there anybody else that wanted to comment before we jump into the next agency? I can also let the Unite Us and also the Fresh to talk about their stuff now, but I think it might be better if we wait to the end of the next segment. Okay.
We're happy to jump in whenever, Representative. We're happy to go at the end, if that's okay.
Okay. Yeah, that sounds good. Michael Werner, I think you're on deck next. Are you ready?
Thank you very much, Representative Dathan. I'm actually going to kick it off to my colleague, Megan Baker, who will begin her presentation.
Great. Thank you so much, Megan. Thank you, Michael.
Thanks again. I'm just going to provide a brief kind of policy context. Evaluating and understanding the legislative precedents, looking at through the context of what happened with the Food as Medicine bill in our legislature last year. So I'll just be walking through kind of that timeline, and then given that the potential paths navigated in that policy space, Mike Werner will then take it to look at our considerations given in this context. And so, like I said, tracing the legislative path of the Connecticut Food as Medicine bill from last year, there was really one major barrier in consideration when attempting to pass a policy of this type through our legislature. The HB 5337, an act concerning a Connecticut Food as Medicine task force and healthy eating incentives, was introduced by the Human Services Committee as a raised bill with really two main prongs. First is that it established a Food as Medicine task force, which was given the task of studying the ways to improve health outcomes for individuals and families via nutritional assistance. So incentives for recipients of supplemental nutrition assistance to purchase more produce and encourage more farmers markets to participate in nutritional assistance programs. The second prong is that it tasked the Commissioners of Agriculture, Public Health, and Social Services with the development of a strategy to increase the numbers of people buying produce at farmers markets. So the strategy had to include two things. It had to include an establishment of a health incentives program where the recipients of the supplemental nutritional assistance received a match in supplemental nutrition assistance dollars for every dollar that they spent, and an encouragement of expanded enrollment in the CFMW, the Connecticut Farmers Market Women, Infants, and Children Nutrition Program, by establishing office hours for the program at Head Start and other early childhood centers. And it required the commissioners, the aforementioned commissioners, to report on the results of implementation of strategies for matters relating to children, education, environment, human services, public health, and appropriations, and the budgets of state agencies. So any increase in farmers market related to the implementation of the strategy, any increase in the enrollment in the Connecticut Farmers Market WIC nutrition program, as well as the fiscal impact on the state implementing said strategy. And as was mentioned earlier, obviously the public hearing testimony highlighted support for the bill to combat food insecurity, a lot of the things that Brent talked about from an asset-based approach, and just highlighting that it's not just access to food in general, but the access to quality food receives an influx of support from community and increasing accessibility in that way. The major contention was from multiple state executive branch agencies about the dollar match concept for fiscal reasons. So I believe DSS submitted testimony expressing concern about prematurely determining a strategy to encourage participation, and really wanted to lead this to that first component of the bill, which had the task force kind of preemptively look at the parameters and goals of improving health outcomes rather than having that explicitly laid out in the bill. And OHS and the Department of Ag echoed those sentiments. So again, seeing stipulations around that section 2, as well as DPH for the requirement of Head Start and the early childhood centers to host office hours for the WIC program, just stating that this mandate would be difficult to accomplish given existing COVID-19 restrictions and straining staffing resources. So from that, the bill's path was that it was modified to omit section 2 following the public hearing stage of the legislative process, and it was tabled for the House calendar, given file number 390. But even with this exclusion, the last action that we saw on this bill in the last legislative session was when it was placed on the House calendar, and it was neither voted on in the House nor the Senate. So kind of just given the contextualization of how this bill and its path in the policy space, I will toss the baton over to Mike Werner to look at our recommendations from our agency.
Thank you very much, Megan, for that. And thank you, Representative Dathan and Foster. And, you know, as we think about this issue, we were talking about it just a few minutes ago about this concept of coordination, this concept of siloing and opportunities for intersectionality. And that's really at the heart of the matter. And it's an issue that runs parallel to some of the work that we do at the commission. And I'm going to briefly talk about it as an example model. And in both cases, our commission was involved. And specifically, I work as the administrator for the statewide senior center work group. And in that particular matter, we have 168, 169 senior centers all over the state. They are independently, municipally run. They don't get state funding. And back in 2016, there was the creation of a senior center task force. In 2018, they created a report. And in that report, they recommended the creation of a permanent statewide senior center coordinator role to be housed within the executive branch. At the time, that wasn't feasibly possible. The legislation promoting that was brought up a number of years in a row until finally in 2021, in place of having this coordinator, they wrote in for our commission to administer the statewide senior center work group. And that's what we've been doing now. And in that process, through the last session, working with legislative leaders, working with the chairs of the Aging Committee in particular, working with the chairs of appropriation, we were able to get a statewide senior center coordinator position funded for the State Unit on Aging within the Department of Aging and Disability Services. And so similarly, I feel that we have another opportunity here. I've sent a resource document to Cass, who I would like to send that out to our group so that they can have it. And in preparation for talking today, I reached out to Kaylee Royston from the Department of Agriculture. And this isn't so much to go deep, but to go wide and to serve as a prompt for all of us to think about this both during the meeting and afterward. And in Connecticut, you know, we have a lot of different resources and opportunities. There's this concept of community gardens, there's urban farming, there's this concept of agri-hoods. I'm going to talk briefly about some of these farmer market nutrition programs, and then within the last year, opportunities for folks to pursue naturopathic medicine that wasn't otherwise previously available. So I'm going to briefly share my screen. First, I'm going to show the resource document that I created, which should be here. And this is for our members. And then on this document, I've gathered a number of links from various articles, various state and nonprofit organizations, which cover the wide spectrum of the concept of nutritious food. And as part of that, I'm also going to share now what some of these websites look like. So, for example, over here in Detroit, they have a new type of agricultural neighborhood which has emerged. There's an organization called the Michigan Urban Farming Initiative, and it's focused on food insecurity. And in this model, it's called an agri-hood. So agri-hoods are a trademark term They come from, it's actually a trademark term from California, and the idea is to have a community which, unlike having being beside a golf course, it's beside a farm, a working farm, and that can actually produce food for the local neighborhood. In this particular instance, in Detroit, instead of being in a neighborhood which is with houses that cost $300,000 to $700,000, there are houses that are worth $25,000, and with only 30% home ownership, yet these places are able to produce thousands of pounds of free food. They have sensory gardens within them. They have the ability for local folks to help contribute and grow the food. And this is a model that is being brought all over the USA. Here's a list of states which have locations for these agri-hood model neighborhoods. Connecticut is coming soon. It's listed as that. And so that's one of the ideas. Recently, the Lieutenant Governor visited the Nourish Indoor Farm, which is a nonprofit that is based out of Bridgeport. It's Connecticut's first not-for-profit indoor hydroponic farm. And they received a grant of $49,999 from the Department of Agriculture. And they have 6 acres that, and within that, they also have a facility which grows nutrient-rich food, which is almost as much as 4 times as nutritious as some of the food that you would otherwise get at a grocery store. There's a level of food insecurity in that area. It's a food desert. And part of the impact of that food desert is a lowered lifespan. Bridgeport has average lifespan of 60 versus 79 in some other parts of the state. So we can see that there's an important component to having healthy food accessibility. And so I'm going to now talk a little bit about one of the other possible opportunities for us, which is naturopathic medicine eligibility. Within the last legislative session, the budget passed a section of the bill which funded the ability for folks who are not Medicaid recipients to receive or to be able to go to naturopathic medicine providers. And those providers have dietary guidance, nutritional guidance, and those are new resources that can help both through prevention and have never otherwise been before available. And that's something that we can share with our different constituencies to help them understand that they have that resource available to them. And so as far as our proposals go, I would again look to the work of our senior center work group as a model where one of the concepts that we're going to be pushing forward is to have summits and where we organize and allow our different senior centers from all over the state to come together in person to have training. And similarly, Connecticut should sponsor and organize a summit of various existing community garden, urban farming, farmers markets, agri-hood entities in conjunctions with nonprofits, municipalities, the Department of Agriculture, DSS, SDE for workshops and idea generations to better understand local capacity and food distribution methods. The organizers could invite speakers from out of the state to better understand innovative systems and methods of distributing nutritious foods and vegetables. And, going back to the conversation earlier from Brent and Representative Foster, at the commission, we like to take this asset-based approach. And through that resource document that I've shared, there's a wide spectrum of these different groups that are all over the state that provide directly to the community access to foods. And what we need to do is bring that together. So I similarly believe that the state of Connecticut should have a dedicated coordinator to do this work, just like we have created for Aging and Disability Services, the State Unit on Aging. That person can take a work group like this, make it a standing work group. They can administer that work group so that it continues. We can bring these stakeholders together and have these types of open conversations. And we can look towards producing these ideas about how food can be medicine, how we can take these different assets that we already have. And I like to use the analogy of baking a cake. And in this instance, Connecticut has all the ingredients we need. It's just that some of those ingredients are in the refrigerator, some of them are in the pantry, some of them are in the garage, some of them are in the basement. What we need to do is bring them together through a dedicated coordinator, perhaps within the Department of Agriculture, and they can continue this work so that it's not simply a short-standing body, but something that lasts longer and that can endure and can continue with this idea generation. Thank you.
Thank you very much, Mike. That was great. We will share all of your links with the group. Cass has your document with all your information. So that's really helpful. And Megan, thank you as well for your words and also your input here. Does anybody have any questions for the commission? Okay, great. I know there's a few other meetings going on and just want to be respectful of everybody's time. Let's see, Representative Kennedy, did you want to put as a co-chair, do you want to kind of have any discussion points before we open it up to the other groups?
Thank you, Rep. Dathan, and I appreciate it. I appreciate everybody being here, and I apologize. I had 2 other meetings this morning, so I jumped on kind of late, but I really do appreciate all of you being here. And I saw the information in the chat, so I'll get to look at things more, a little bit more. So thank you, Rep. Dathan. Thank you, everyone, for being here. We really appreciate it. Something is really important to all of us.
Great, thank you so much, Representative Kennedy. Just wanted to, I know About Fresh might do a better presentation going forward, but I wanted to open up the discussion to them as well as Unite Us to see if they wanted to weigh in on today's discussion going forward.
Thanks, Representative Dathan. My name is Adam Shayevich. As I said earlier in the meeting, I'm the Chief Program Officer at About Fresh. I really enjoyed listening to the conversation. I think this, this question of coordination comes up a lot in our work, and we work with states and organizations throughout the country to provide or to address the needs of lower income patients in particular to access the fresh food they need. We designed Fresh Connect, and I believe we're going to be presenting this in more detail at your next meeting, so I won't go into it in too much detail, but we designed Fresh Connect to emphasize the autonomy of our Fresh Connect card holders. It's a prepaid debit card that's programmed just to purchase fresh produce. I think state coordination, the question is, coordination for whose benefit? So at About Fresh, we've really focused on the autonomy, agency, and independence of the cardholders, so they can shop where they like to shop. They can buy food, healthy food that's aligned with their cultural preferences. They can get access to local groceries that they like to, where they like to shop for whatever reason. So when we think about coordination as a question, we start from the perspective of our cardholder and what level of coordination is going to give them the best experience and preserve their, as I said, autonomy, dignity, agency to take care of themselves and their families. I think in Massachusetts and many other states in which we've worked, or many other organizations, the kind of coordination you're talking about a place for people to convene, share programmatic ideas, legislative ideas, policy priorities across agencies and across organizations is very, very helpful. Centralizing program delivery, on the other hand, often gets in the way, at least in our experience, of the beneficiary and their best experience, because they have to, the system they navigate becomes more important than the relationships they have with the organizations and markets, in our case, that they most value. So that's the only, that's the question I would raise, as you think about coordination, for whose benefit is it? And again, what is going to give the end user, in our case, a cardholder, the best experience to express their own preferences. So I'll leave with that. I'd love to hear from, I know Unitas is on the line, want to give them space. And I look forward to talking with all of you in more depth next time you meet about the Fresh Connect program.
Thank you, Adam. That's really helpful. I think also, folks would love to hear what About Fresh is doing maybe in other states with, programs like this and how it might be working here in Connecticut going forward. I'm looking on my screen to see if I can find who about Unite CT. Is that Melissa? There you are.
Yeah, hey, Rep. Dathan. I do see that Michael has a hand up. So if it's About Fresh, do you want to?
Oh, yes. Sorry, Michael.
Yeah, thank you very much. I just wanted to respond briefly to Adam, and I agree. And with the Senior Center Work Group, there's a similar concern. And we have our senior centers, which are municipalities, right? And we love our local control in Connecticut. And so the idea isn't so much to have this centralized, top-down, prescriptive oversight, but rather to have, and this would be kind of built into the philosophy of the position, but rather to have a central coordinating place that allows for resources to be shared, but not to have mandates be presented. And we're working on this issue when it comes to certifications, but we realize that different communities have different capacities with their senior centers. We look at a city like Hartford, it has like 4 or 5 senior centers. We can look at other more rural areas. Maybe they're open, maybe they only have 1 employee, versus some municipalities, they have their own whole entire dedicated senior centers. So there's different capacity levels. And the idea is to respect and honor all of these different participating stakeholders, but to provide a vehicle for them to come together and to have a coordinator to be able to share resources, share opportunities, and to better interweave these different resources that we have in a way that's holistic. Thank you.
Thank you, Mike. That's really great. Melissa, you ready to jump in?
Yeah, sure. Just a quick couple thoughts, and we can go through, what Unitas does more in depth later. But I think, this concept and this thought process around coordination is really synergistic with what Unitas does. And we really think about, how do we coordinate? How do we make sure that we're all collaborating and creating visibility into an individual's journey throughout all of the touch points throughout the state? So we actually provide a technology platform where government entities, hospitals, health associations, we actually partner with CHA, and they helped us build out our network in Connecticut, but really bringing everyone together, community-based organizations as well, onto this platform to actually track the individual journey and where they're touching all the different services within the state. So whether someone's enrolled in SNAP or enrolled in WIC, or they're getting a medically tailored meal from their physician, or an emergency box of food from the local CBO, you can see all that within our platform and coordinate that care across agencies. That's just the tip of the spear for what we do, but I think that's kind of the most relevant thought that's coming up now is, how do we actually coordinate this for the individual on the ground? And then Max, if you want to share any other thoughts, jump in.
Sure. So we're a digital closed loop referral platform for those who aren't so familiar, and we're really designed in a way to enhance care coordination throughout the health and social care systems. And to Adam's point, we've developed our platform with the client, the patient, the individual, the family in mind, making it easier for them to navigate the system by empowering the providers to better manage those transitions between care. So the end user, the client, ultimately receives better care, more holistic care, to Michael's point, in a way that strengthens that relationship with the provider. And then the individuals who know the system best, the providers, are the ones who are managing the transitions between organizations, so that the individual or the family who is just trying to manage day-to-day responsibilities doesn't have to do that. Our health and social care systems are complicated, and we're seeing significant results across the country through our work by just slightly shifting the model of social care delivery from placing the responsibility on the individual to placing the responsibility for care on the provider system.
Thank you, Max. That's really helpful. I think we'll have maybe a better, little bit more robust discussion next time with both of your organizations, because I'd like to explore that a little bit more. I think that's really important. Just wanted to check in with the group here to see if there was anything else that we would like to talk about before our next meeting. I think, I think Rep. Foster, Rep. Kennedy, and myself kind of need to huddle and kind of think through exactly the direction and where we want to take this for the next session. I think today we've had some good exploring about how we have some sort of standing committee, might be an interesting thing, but really also how we can see that this might work within our budget going forward in Connecticut, and really kind of get a better idea of funding and how that might look either from the feds or from other sources. So I think there is some work we need to do, and really would like to make sure that when we do have our next meeting in January, I can't even believe I'm talking January, that we, have some sort of good ideas that we'll be able to then talk about taking to the next level of putting together legislation later in January for approval and going through the committee process. Wanted to get any sort of final thoughts on the discussion today, or any suggestions on what we can do to take it going forward. All right, silence is all the answers. Okay, so we will keep you in the loop. I also wanted to give a great shout out to our wonderful administrator, Cass Bruin. She has really been fantastic in helping us get organized and pulling together emails, following up with people. She has been absolutely wonderful, and I'm just announcing that she is moving on from the House Democrats and being part of this committee. And we're sad to see her go. I'm not sure if your next position is a public knowledge yet, so I'm going to let you figure out how you want to announce it or not. But we are sad that she's not going to be part of this, but she has been really wonderful in keeping us together. So thank you, Cass. I hope everyone has a wonderful holiday season. And oh, there's my other friend, Heather. Nice to see you.
Nice to see your update then.
Oh, thank you. I hope everyone has a wonderful holiday season. I know there's a lot going on, and really your time and your effort in taking this issue going forward is really important to us. And thank you all for the great conversations today, and looking forward to taking it to the next level in early part of the year. If you do have any comments or any sort of thoughts, please forward to Cass right now. And then as we get a new administrator, we will keep you in the loop of that. But she will, she'll be here for the next several weeks still. So appreciate that. If there's nothing else, Representative Kennedy, did you want to say any closing words? I know you're balancing between 10
Thank
things.
Rep. Dathan. I'm listening.
I know, it's hard.
Good morning. Thank you, everybody, for your presentation today. It was very, very helpful. It always is. And I look forward to our next meeting. In the meantime, everybody have a wonderful holiday if we don't meet before then.
Sounds great.
Yeah.
Thank you so much, Representative Kennedy. You have a wonderful holiday season too. With that, I will adjourn the meeting and I hope everyone has a good rest of your day. Take care.